Good morning. I'm Murli Varma. Welcome to the 10th Annual Conference of the Welsh Division of the British Association of Physicians of Indian Origin. It is great to see such a great attendance early on a Saturday morning. In keeping with Indian tradition, we will start with a prayer that will be sung by our lovely couple, Mr. Hemang Mehta, consultant orthopedic surgeon, with his wife, Dr. Kinnari Mehta, consultant anesthetist. Over to you, Hemang and Kinnari.
Asato ma sadgamaya.
Asato ma sadgamaya.
Tamaso ma jyotirgamaya.
Tamaso ma jyotirgamaya.
Mrutyurma amrutam gamaya.
Mrutyurma amrutam gamaya.
Om Shanti Shanti Shanti.
This Sanskrit prayer means, from ignorance, lead me to truth. From darkness, lead me to light. From death, lead me to immortality. Lord, grant me peace in body, mind, and spirit. Good morning, everyone. Namaste, Boreda.
Thank you, Hemang and Kinnari, for that beautiful rendition of a lovely prayer. I will now request Dr. Hasmukh Shah VEM, Secretary of BAPIO Wales, to kick off our conference. Hasmukh is a GB Principal and Visiting Fellow, University of South Wales. He is a trustee of multiple charities and has raised thousands of pounds for good causes. He is a member of the First Minister's BAME COVID-19 Advisory Group and had been honored by the then Prime Minister Theresa May as part of the NHS at 70 celebrations. Finally, those who know him will agree that he is very aptly named because his name would translate as smiley face. Dr. Hasmukh Shah.
Distinguished guests, colleagues, and friends, it gives me great pleasure to welcome you to this 11th BAPIO Wales Annual Conference, which is held virtually in this unprecedented time. We had already postponed our face-to-face conference twice, in April and October 2020, not realizing that pandemic will be going stronger over a year after it started. However, the fact that we are doing a Zoom meeting has given this an international flavor with the Union Health Minister of India and also the Vice Chancellor of Manipal Group of India addressing us latest in the program. If nothing else, the pandemic has taught us the telemedicine and driven all of us to become the fitness fanatics. We have a packed program with renowned speakers who are internationally renowned in their field, apart from the minister and senior policymakers. And it would be fascinating to hear the effect of the pandemic on our society and post-COVID scenario. BAPIO Wales is proud to have contributed to the First Minister's Risk Assessment Subgroup and the Race Equality Action Plan, and will continue its campaign on equal opportunity and inclusion. We have, however, very fortunate in having a government which is totally committed to a fair society, which makes our task more pleasurable. In 1945, NHS had 1,000 BME doctors. BAPIO UK realistic estimate of doctors of Indian origin in UK are 15,000 GP, 18,000 consultant, 18,000 specialist doctor, 14,000 trainee doctors, and 15,000 dentists. 30% of medical school intake and 70% of dental school intake are of Indian origin. In short, we have 65,000 doctors and 50,000 dentists, so total 18,000 doctors of Indian origin. And I urge our all doctors of Indian origin to work together and on an equal term, and let us make our NHS even better, world-class health service. The conference is being held as a webinar, and we have over 400 registrations apart from nearly 50 panelists. The attendees are able to put a question in the chat box, and time permitting, we will try to put it to speakers. Please do observe the usual etiquette of civil disclosure. Enjoy the conference and do provide us with your feedback. The conference provides 6 hours of education and a certificate will be sent to you. Stay safe in the meantime. Protect yourself and NHS. Thank you.
Thank you, Hasmukh. I will now invite Professor Keshav Singhal, MBE, to address the conference. Keshav is an orthopedic surgeon who wears multiple hats. As chair of BAPIO Wales, he campaigns for equality, diversity, and promotion of clinical excellence. He chairs the First Minister's COVID-19 Risk Assessment Subgroup, which devised the first COVID-19 risk assessment tool of the UK, which is in widespread use, helping to sustain the NHS during the pandemic. He was awarded the fellowship of the prestigious Learned Society of Wales last year. I give to you, Professor Singhal.
First Minister, Ministers of Health for India and Wales, Lord Kakkar, Deputy Minister and Chief Whip, Director General Health Services, Chief Medical Officer Wales, Her Excellency the High Commissioner of India, Members of Parliament, friends and colleagues. It is exciting to see you all here on this conference focusing on COVID-19 and its impact on the society. This pandemic has laid bare the fault lines of our society between the privileged and the underprivileged, between friends, colleagues, and neighbors. In my role as the chair of the First Minister's Risk Assessment Subgroup, it became obvious that this pandemic was affecting the poor and the deprived disproportionately, probably because of various comorbidities associated with obesity and unhealthy diet. We found that apart from age and ethnicity, a major determinant of mortality from COVID was obesity, hypertension, and diabetes. And it also became clear that ethnicity and key worker status were inextricably linked, because majority of people working in the healthcare service, social sector, and transport sector are from ethnic minorities and were disproportionately affected. We have seen during the pandemic that the rich have become richer and the poor have become poorer. Likewise, the social and mental health impact of this disease has been felt more starkly by those in the deprived segment of our society. And we have seen an upsurge in mental health problems. Unemployment and underemployment have caused deep financial hurt to these groups, whose existence was already precarious. The furlough scheme and various other government measures have prevented mass unemployment, but have led to an unprecedented level of public debt, which will take generations to pay off. This pandemic has also highlighted the importance of a democratic society where the government's actions can be challenged and scrutinized in a fair and transparent way. And it is fair to say that it was a failure and early lack of international coordination and cooperation that led to this pandemic, which has now caused over 2 million deaths worldwide. However, it is not all doom and gloom, because despite having no blueprint or precedent, governments worldwide have dealt with the pandemic in their own way and reasonably well. And because of the international efforts, what could not have been imagined a year ago has become a reality. A multitude of very effective COVID vaccines are now out. The challenge is now to ensure that our people do not fall into a conspiracy theory trap and undergo these vaccinations. During this pandemic, our society found new community spirit, helping the poor and the underprivileged. We became more resilient and also learned to rebalance our work-life commitments. There may be an appreciable and long-lasting impact on greenhouse gas emissions because of the way we have changed our work with more remote working. We also, as a society, use the spare time on our hands to take up some form of meditation, yoga, mindfulness, and other exercises, which actually will lead to a better public health. We saw new role models like Sir Tom Moore and Marcus Rashford coming forward and campaigning for greater compassion and help for the poor. Telemedicine is offering us new ways of delivering care directly to the homes, though we need to do more to tackle the mountain of the waiting list. However, friends, all this suffering from this pandemic would be in vain if we do not take this opportunity to strengthen our public health infrastructure and focus on improving the life of our nation. In particular, knowing that obesity and its related comorbidities have contributed significantly to the fatality from COVID-19, it is incumbent on our governments to ensure that they tackle the issue of obesity and unhealthy food on a war footing, focusing on the high sugar and salt content of our packaged food. Sports and exercising needs to be made compulsory in our school curriculum, and the adults need to be incentivized to exercise more. Friends, the defining image of this pandemic has to be our Prime Minister being cared for by 2 immigrant intensive care nurses, and his fulsome praise on the excellent and life-saving treatment he received from them. As a society and as a nation, we have been gripped with the issue of immigration for some time now. And BAPIO has been lobbying the government on certain travesties arising, particularly the healthcare surcharge and the adult dependent visa issue. On the healthcare surcharge, we have successfully campaigned to overturn this unfair charge. And we are currently talking about the adult dependent visa issue. The argument that adult dependents of healthcare workers would be a drain on public finances is completely fallacious, because the nation did not pay for the medical training of these healthcare workers in the first instance anyway. We were the first to campaign for a risk assessment tool way back in February and March by highlighting the disproportionate impact of this pandemic on BAME healthcare workers. The Welsh government has been very proactive, setting up the First Minister's risk assessment subgroup and accepting our recommendations with a risk assessment tool, which has now been used by pretty much most of the NHS and in all public sectors in Wales. We continue to provide a major input into the Race Action Equality Plan of the First Minister, and are confident that with his determination, we will see a fairer and more equitable nation in the very near future. Even though all of us are at a low point currently, at the peak of the second wave, I feel that eventually some good will emerge from this catastrophe. And I hope that as a society, we will become more compassionate, tolerant, and emerge with an overall better public health. Thank you so much for being with us this morning. Bye-bye.
Thank you, Keshav, for outlining the challenges posed by the pandemic. I now invite Ms. Reena Goyal, consultant ophthalmologist, to introduce our First Minister, the Right Honourable Professor Mark Drakeford.
Good morning. I have the pleasure of introducing Right Honourable Mark Drakeford, MS, the First Minister of Wales. He is an unlikely politician with a deep academic background, having been a professor of social policy and applied social sciences at Cardiff University and previously at Swansea University. He and BAPIO have forged a strong relationship over years, starting in 2016, when, as a health minister, he supported the All Wales BAPIO MTI Fellowship Scheme. He has had an exceptional political career, serving as Minister for Health and Social Services, Cabinet Secretary for Finance, and now the First Minister of Wales and member of Her Majesty's Privy Council. But from now on, he will be known as a man who bravely led a country through the worst pandemic in living memory. A man who gave comfort to most of us during these troubled times and who gave us a hope for brighter tomorrow. Please welcome Mark Drakeford.
Well, good morning, Boreda Ichigid. Thank you so much for that very warm introduction. You described me as an unlikely politician. I sometimes think of myself as a completely accidental politician who fell into this job by accident rather than by design, and largely because of the way in which I was able to work alongside the former First Minister, Rhodri Morgan, who was such a strong supporter of BAPIO, such a strong participant in earlier events, not of this sort, of course, where we're online, but when we were able in happier times to get together in Cardiff City Hall and so on. And I look forward to the days when we're able to do that again. In the meantime, I do think you've assembled the most extraordinary program for today, a program that involves both national and international speakers. It's a privilege for me to share a platform with ministers and senior academics from India, as well as the list of participants from closer to home. I hope you'll forgive me for saying that I am especially pleased that this has provided a platform for our own Chief Medical Officer, Dr. Frank Atherton, to launch his special report, reflecting on the extraordinary period in our lives that we have all lived through. It's a very important report. It's already attracting widespread interest, and this event provides a platform in which the significance of the report and the significance of this audience can come together to underline its contents. Now, I'm not going to try to cover ground that many others will be able to with greater expertise. I'm simply going to reflect on two aspects of life in Wales today. I do want to say something about the last 12 months, but I want to say something about the future as well. We were remarkably fortunate here in Wales that at the very start of this global crisis, we had practicing frontline clinicians who were able to alert us way back there, as you heard Professor Sengal say, in February and March of last year, to the early signs of the disproportionate impact which coronavirus was having on frontline staff in health and social care, where those staff members were drawn from BAME communities. And that allowed us very quickly to be able to set up the working group chaired by Professor Judge Ray Singh, which has led to a whole series of practical things that we have been able to put in place in Wales. Immediately, as you heard the chair of BAPIO Wales say, it produced that self-assessment tool, a self-assessment tool that has been used not simply in the health service here in Wales, but in public services more widely, and not just here in Wales either, but used right across the United Kingdom. A tool that has undoubtedly saved lives. And the fact that we were able to assemble that group so early on, get that work done in the early stages, promote it across our public services, I think is a tremendous tribute to those frontline members of staff who, despite being hugely busy in dealing with coronavirus itself, were able also to make that very significant additional contribution. And that contribution continues to today. Our focus at the moment, as you will all know, is on the remarkable vaccination program that is being carried out right across Wales. Over 400 GP practices involved in vaccination in the past week. A huge collective effort right across our NHS. And I am immensely grateful, often to those young GPs from BAME communities who are going out there and making the clinical case for vaccination amongst communities where there may be hesitation, where there may be misinformation, and we have a collective obligation as clinical leaders, as political leaders, as faith leaders, in all the different things we can draw together to go on passing that message out to communities. The vaccine is safe, the vaccine is effective, the vaccine is there for you to have. And as I say, I'm hugely grateful to those people who are going out there on all our behalves, making that case to all. Now, as you heard Professor Singhal say, coronavirus has exposed the inequalities in our society, but it has also drawn to the surface the powerful sense of social solidarity that continues to be a characteristic of communities here in Wales. And we need to foreground both of those aspects, both the difficulties we have experienced, but the strengths we've been able to draw on as well. In this great vaccination effort, it's only possible because of the contribution not simply that clinicians make, but all those local authority staff make in setting up centres and making sure they're open, making sure they're fit to be used, those volunteers who welcome you as you arrive, make sure that you feel well looked after, who know that at the age of 80 plus, leaving your own home and visiting a centre will be a challenging experience. And knowing that when you get there, there's somebody to welcome you, somebody to make sure that you know that you are safe and the centre of our concerns is, for me, the latest practical example of that social solidarity that has been such a strong characteristic of our response in Wales. Let me look forward a moment as well from the immediate experience. I'm often asked when I'm doing interviews, how do we explain the UK experience? How do we explain why coronavirus has hit us especially hard? And sometimes that question is phrased at what went wrong? What were the mistakes that were made. And it's absolutely right and proper that we think of those questions. And I know that will be part of the workshops that the conference will be looking at this afternoon. But I want to answer the question in a different way for a moment. I want to suggest to you 3 reasons why we have lived through the difficult experience we have. First of all, we are a small and crowded island. And we know that coronavirus thrives in conditions where people live nearby to one another. And we know that in Wales, it is those poorer communities where people live in housing that is small, that is close to one another. And we see the results of that in the experience that we have all lived through. Secondly, coronavirus hit us at the end of a decade of austerity, a decade in which our public services have not had the investment that they needed, where people who work in our health service had seen their wages held down year after year, a decade in which the underpinning of communities had been eroded because money was always in such short supply. Coronavirus hit the United Kingdom at a point of real vulnerability. And that underlying lack of investment, that decade of resource starvation, also, I think, helps to explain why we have had the experience that we have. And thirdly, the United Kingdom has become the most unequal society in the whole of Europe. And the experience of coronavirus is the experience of inequality, as Professor Sengal set out in his opening remarks. And that is why it was so important that when we set up the group chaired by Judge Ray Singh, not only did it look at the immediate impacts of the virus, but it has looked at, under the leadership of Professor Emmanuel Ogbonna, it has looked at the underlying socio-economic causes of inequality amongst BAME communities here in Wales. And all of that will lead to our Race Equality Action Plan. And I am determined as First Minister that despite the fact that we are in the closing weeks of this Senedd term, we will publish that plan before this Senedd term is over. I want that plan to be there for the incoming government after the elections to be able to take it up and make it tangible in the lives of communities here in Wales. That is a lesson we have to draw from this awful coronavirus experience. I am with Professor Sir Michael Marmot, a great friend of us here in Wales. But as we build back from coronavirus, our aim must be to build back fairer, because you cannot build back better without that future being fairer as well. So much good and important practical work has now been done in Wales to help us to create that sort of future. That's what the Race Equality Action Plan will set out for us. It will draw on the experience of frontline workers, workers represented so powerfully through BAPIO here in Wales. Together we can go on making that difference. Thank you so much for everything you do, both today, but to help us to shape that future. Today's conference will play a very important part in all of that, and I look forward to being able to share parts of it with you. Diolch yn fawr iawn I chi gyd.
Thank you, First Minister. Thank you for clearly outlining the Welsh response to the COVID pandemic and for contributing some of your valuable time to our conference. Thanks again. I now invite Professor Singhal to introduce our keynote speaker, the Right Honorable Professor, the Lord Ajay Kakkar.
The Right Honorable Professor, the Lord Kakkar, PC, is an illustrious son of an equally illustrious father, late Professor Vijay Kakkar, who pioneered and revolutionized the treatment of deep venous thrombosis prophylaxis, saving countless lives across the globe. He is the Professor of Surgery at University College London and Director of Thrombosis Research Institute, which had been founded by his father. He's also the chairman of UCL Partners Academic Health Science Partnership, chair of the King's Fund and the UK Biobank. He completed his medical degree at King's College Hospital and received his PhD from Imperial College London. His research interests include the prevention and treatment of venous and arterial thromboembolic disease and cancer-associated thrombosis. He was created a life peer in 2010 as a crossbencher. He is chairman of the Judicial Appointments Commission and a member of Her Majesty's Most Honourable Privy Council. Lord Kakkar.
Professor Singhal, First Minister, Excellencies, ladies and gentlemen, thank you for having invited me to join you on the occasion of the annual conference of BAPIO in Wales. Although we are forced to conduct the proceedings virtually, the fact of our separation does not detract from my great pleasure in being able to participate today. It is a particular privilege to be here today at this landmark meeting, as the British Indian Nurses Association in Wales is also launched. I'm sure we will join in paying tribute to all the nurses, doctors, and indeed every member of the team in each hospital and clinic across Wales for the truly remarkable commitment and determination that they have shown throughout the last 10 months. Much, of course, has been learned in these past difficult months. An unprecedented research effort has delivered new knowledge, derived through a remarkable collaborative effort involving the basic and clinical sciences, which has been shared at scale and pace globally. The resulting advances and improvements in community and hospital management of COVID-19 and the establishment of novel vaccine platforms have not only aided our fight against SARS-CoV-2, but laid the foundations for the world to be better prepared for future pandemics if we are ready to learn the lessons from our current experience. At the same time, the public and the institutions of government have come to understand something well recognized within our professions for some time: the striking disparity in health outcomes attending different communities and ethnicities. Both sets of these lessons need to be remembered together once the pandemic has passed, so that we might build a better future for all our fellow citizens. As we're all too aware, the pandemic has challenged every arm of government, every aspect of the health and care system, and every community across the country. It has not, however, affected every community equally. Our understanding of the multifactorial causes of differential exposure to the SARS-CoV-2 virus and susceptibility to the progression of COVID-19 to a more severe disease is improving and will continue to improve. I look forward to hearing more on this topic during the sessions later today. For now, I will limit myself to one comment on these analyses and how we might interpret them. We must not limit ourselves to identifying and tackling only proximate causes for the different clinical outcomes we have observed across different communities. Of course, occupation and housing impact exposure. Diabetes and heart disease impact progression. But none of these risk factors are random inevitable or unmodifiable. We must endeavour to look beyond for the causes of the causes and the causes of those causes if we want to reduce risk in a sustainable fashion and thereby improve individual patient and population outcomes. The truly remarkable progress made in vaccine development means that we can be optimistic about COVID being long in the rearview mirror, at least at the level of a society-altering pandemic, by the time we can draw a definitive picture of who was at what risk and why. But the range and shape of disparities is already clear, especially at the community level, and has been clear since the spring. This magnitude of ethnic disparities has shocked the country. According to the most recent report from the Office for National Statistics, analysing data from March to July, death rates for almost all ethnic minorities are higher than those among white ethnic groups. For men from Black and Bangladeshi communities, the rates are 3 times as high after adjusting for age. Adjust for geography, socioeconomic and health status, whilst of course always keeping in mind that those adjustments represent explanations, not justifications, and the rates are still significantly higher. For those of Indian origin, the age-adjusted rates are twice as high among men and 80% higher among women. It is hardly surprising when figures like these are being regularly presented to the nation that the pandemic has shone a brighter light on ethnic disparities in health outcomes than any other event in our lifetimes. But attention is not action, and action would be urgently required even if everyone received a vaccine against the virus tomorrow. Because while the pandemic has exposed these patterns, has augmented them, it did not create them. Occupation and housing impact exposure to the virus, but they also impact exposure to pollutants and stressors, which cause all manner of respiratory and cardiovascular disease. Diabetes and heart disease impact the progression of COVID-19, but they also impact the progression of dementia. This is, of course, no bold claim. Social determinants common to all ethnicities are now well established as the predominant predictors of variation in population health outcomes, thanks to decades of research, as we've heard from the First Minister, most famously by Professor Sir Michael Marmot, but by so many other workers as well. What has too often been overlooked is the unequal distribution of these factors between communities, especially ethnic minority communities. While there are notable exceptions, ethnic minorities are typically overrepresented in categories associated with poor health and underrepresented in categories associated with good health. The tragic and irrefutable evidence generated by COVID-19 presents an opportunity to think about health more broadly, to take a more holistic approach, which encompasses housing, education, the environment, and material resources. These are the foundations of our health, and they should be at the center of health policy in the future. The fact that ethnic minority groups may disproportionately benefit from an agenda tackling inequalities in the social determinants of health is material to an organization such as BAPIO, but would be equally true if our motivation, analysis, and interventions excluded consideration of race and ethnicity entirely. This distinguishes the traditional set of common social determinants from a second set of causes more directly related to ethnicity itself. These are the role played by bias and marginalization in mediating outcomes. But evidence from an ever increasing number of studies suggests that these impact damagingly in a consequential fashion. Navigating these nuances and the bundles of ideas they represent and refute will not be straightforward, even accounting for the changes in perception and appetite for reform brought about by the pandemic, a point I will return to shortly. It is also important to highlight another area of disparity relevant to us today in the healthcare workforce. This has been an immensely trying time to be a healthcare professional. By virtue of the fact that the ethnic minorities make such a substantial contribution to the NHS, the physical and emotional burden has fallen particularly heavily on these communities, which staff around 20% of the NHS workforce and some 40% of the general medical register. The personal sacrifices made by those who care for us and our loved ones when we are most vulnerable has been recognised anew by the general public. That recognition and heartfelt support must be translated into progress that the workforce rightly deserves. Reports detail the consistent pattern of declining ethnic minority representation throughout the medical career pathway. Reports from the Royal Colleges, including the Royal College of Physicians. I know that we're going to be joined by Professor Goddard later today. And the King's Fund, where I am chairman, and multiple NHS bodies, amongst others, consistently make this point. It's widely recognised that students of Indian origin, as well as those from some other minority backgrounds, are overrepresented at medical schools. But representation falls in postgraduate training, and again at consultant level, and then again among senior consultants and those serving in leadership positions. The pattern is replicated in the career pathway of other health professionals, including nurses and midwives. And there is a similar pattern in disciplinary actions, where the evidence suggests that ethnic minority clinicians are more likely to be subjected to internal disciplinary procedures and more likely to be referred to the regulators. Strikingly, the primary source of these disparities are referrals from employer organisations rather than referrals from the general public. It has been documented how negative experiences impact on the well-being and health outcomes of staff themselves, as well as their career progression and the performance of the trusts in which they work, and of course, the experience of their patients. And so again, newfound enthusiasm for change and improvement is welcome and overdue, but it must be matched to the nuance of the challenge and led by the evidence. The Royal College of Physicians' analysis of racial disadvantage in the hiring of CCT holders has been incorporated into the NHS Workforce Race Equality Standard. The King's Fund has documented successful interventions related to unequal staff development and progression. The NHS, as set out in the long-term plan, has committed to its constituent organisations being led by boards which are representative of the communities they serve, although definitive targets will only be finalised in 2022. These are only small pieces of a big puzzle. More action is required at the local and national level. Which brings me to what I consider to be an extremely important role for organisations like BAPIO and its membership in shaping the actions which might follow from the unprecedented attention being paid to ethnic disparities in health. institutional vehicles with the potential to make meaningful change have been and are being established. To take just two examples with which I am familiar, the NHS Race and Health Observatory was established last spring with objectives which include the making of strategic policy recommendations. Its board was formed this month, and I will have the privilege to join that board in July of this year. And last summer, the government established its Commission on Race and Ethnic Disparities, with health as one of the 4 priority areas, alongside employment, education, crime, and policing. These vehicles sit at a junction on a hill. It has been an effort just to reach this point. My late father arrived in the United Kingdom in 1961 to complete his postgraduate surgical training. Thanks to his perseverance and the perseverance of many others, my experience in the profession has been much different. From here, there are lots of easy routes down and away from the goal, as well as multiple arduous uphill roads that lead to nowhere. But some of them go towards the summit. If the pandemic and its disparate effect have changed perceptions and increased appetite for reform, then the incline up this hill might be a little less steep than it was 12 months ago, and the lift a little lighter. Still, these vehicles will only go as far up the hill and in the right direction as their fuel can take them. That fuel, that energy, is engagement and evidence. Like any fuel, quality matters. And while it will inevitably take many forms, evidence will always be most effective in terms of identifying problems and designing solutions when it is contextualized and communicated by those with first-hand experience. Engagement and evidence are essential. I know BAPIO has already engaged with the government's commission submitting evidence to the health subgroup. I encourage the organisation, its leaders and membership to prioritise these engagements, to continue to compile, contextualise and communicate high quality evidence. I believe this moment represents a unique opportunity, but progress is not inevitable. It will require our effort. I'd like to close by reflecting on the wider contribution physicians of Indian origin have made to advances in healthcare and the life sciences, and will continue to make in the future. The conduct of high quality fundamental and clinical research and the adoption of innovation at pace and scale is at the core of practicing medicine. The UK's national prioritisation of medical sciences makes us global leaders. As Bill and Melinda Gates have written, COVID-19 meant that global health became local. We have been presented with challenges typically associated with developing countries. Our paths through the pandemic have been entwined, and we have exported our solutions and imported others to our mutual benefit. The design and execution of the recovery trial, the utilisation of UK Biobank's unique research resource, and our sequencing of over half of all viral genomes that have been submitted to the global COVID-19 database all serve to illustrate our potential to make a transformational difference around the world. As with workforce and health outcomes, what we have learned and what we have proven to ourselves must carry over. Whether it's preparedness for the next pandemic, preventing antibiotic resistance, or developing an ethical framework for applied artificial intelligence, our research and innovation, our leadership can make a huge difference for populations and patients far from home. BAPIO's reach is extending with an educational academy and an institute for health research, initiatives I strongly commend and encourage members to participate in. With that thought in mind, I look forward to today's excellent programme and to the work we have ahead. Thank you.
Thank you, Lord Kakkar, for sharing your insightful thoughts, highlighting the need for a holistic approach to the COVID-19 pandemic and the particular issues that are faced by BAME doctors. Thanks again.